So I think that this is a portrait of the future. We expect this drug will be approved by the FDA in the next several months. We're going to be doing a study here in Eugene. Actually, we're running it nationwide because we're part of this large organization called US Oncology. We're going to look at 2,000 patients, and we're looking for anybody with cancer as long as their tumor has CD30 on it. We happen to know that lung cancer occasionally has CD30. Thyroid cancer occasionally has CD30 on it. Cervical cancer sometimes has CD30 on it. So what's going to happen there? I don't know. You know, it's going to be a fun experiment, and I'm pleased to say that I'm doing the whole darn thing. It's going to be fun to see. I mean, this is the drug that everybody's talking about right now in a lot of circles. So right here in Eugene, we get to do these things. Next slide. So, you know, I've said this a couple times, but if 1971 we didn't know the laws of gravity, I think that in a lot of cases, you know, the hard work of Lymphoma Leukemia Society supported researchers have really worked out a lot of those laws of gravity. We don't know them all, but we know a lot of them. And with it, we have a much better understanding of the molecular basis of cancer. And now instead of taking 50 drugs to find one, we just kind of think smart about it. We work on one really hard, and that one might succeed, much more so than other. Drug companies are just lining up to make drugs because they understand that they can work now. And improve supportive care. I mean, we've come a long way from where we were even just 10 years ago in preventing some of the side effects of treatment. And there's some early victories. You know, in lung cancer, we know that a small percentage of people have EGFR mutations. Well, these drugs work really well for them. Just 2 years ago, we discovered these ALK mutations, and virtually everybody who's been started on an ALK inhibitor is still alive with their disease. And these drugs have been around for 2 years. Lung cancer, we don't know how well it's going to go. Melanoma is the star of the moment right now. The American Society of Clinical Oncology has just had their meeting. These drugs are going to be approved in ones with mutations in BRAF. 50% of melanoma patients have them. They respond incredibly well. I mean, this is melanoma, for crying out loud. Melanoma never responds to anything. c-Kit, here's kind of an odd one. Gleevec, actually, in a small population of melanoma patients, works incredibly well. Breast cancer, we know about HER2. CML, I mean, here's the poster child. Non-Hodgkin's lymphoma, this is a disease I have a personal research interest in, and we have a handful of drugs that are just knock your socks off drugs in non-Hodgkin's lymphoma and CLL, and I'm pleased to say that right here in Eugene, we've treated more patients than almost any other academic center in the country with some of these drugs. And that's something I feel real proud of. AML, we know that there's a population that has this mutation. You could give them a vitamin called Atra, and their leukemia just melts away. Sarcoma has c-Kit, VEGF, and kidney cancer. I mean, the list is getting longer and longer and longer. I could put thyroid cancer. I could have put more up there. I mean, things are changing really quickly. So that's the current day, right? So what's the future? So this is a presentation of what I would call the oncogenome, right? Take 100 patients with colon cancer, okay? Sequence their tumor from start to finish. Every little dot here represents one gene, okay? So if you go down this way, and then back up this way, and then back down this way, and then back up this way, and this and back and forth, that's 30,000 genes, okay? That's the human exome, if you will, or all the proteins in the body. Now, if you go through that colon cancer and you find a mutation, you get a dot. So here's a mutation in this protein, a mutation in this protein. You know, not a whole lot of patients have them. If you get 2 mutations instead of a dot, it starts becoming a hill, okay? And so we take 100 patients with colon cancer and we find, well, gosh, this protein right here, this protein right here, and this protein right here, these are the ones that seem to be causing the colon cancer. And if we've learned anything, it's that if we know the target, we can make the drug. And so now instead of guessing, well, maybe this drug will work, maybe this drug will, maybe, now we say, oh, we just need a drug for that. Oh, we need a drug for that. How do we do this? You know, again, it's data driven. And the first cancer genome came out about 2 years ago. There's about 400 of them that have been sequenced now. I would love to challenge the Lymphoma Leukemia Society to sponsor sequencing of lymphoma genomes. It's not currently on the docket, but at the cost of $10,000 to $15,000 per genome, it's a shame that it's not. I'll talk to you more about that later. So it's a reverse pitch here. All right, next up. And really this gets down to personalized medicine, right? Because what we find in myeloma is there might be about 8 mutations that are important, but it might be that for any one individual it's just 4 mutations that are key, but it might be a different 4 between patient to patient. And so instead of responding to one drug, it might be the next drug. And you know, we're getting into the real mechanics of the cancer cells here, and I think personalized medicine is literally just now starting. I mean, we're in discussions about how do we make these trials happen, and they're on the discussion board right now. This is a new world. We're abandoning the old trials network because it's so inefficient and so forth, and we're just trying to figure out, okay, how do we do this? Now that we have all the information, how do we partner the mutation to the drug to the patient so that you get the right drug for the right patient at the right time? Next up. So with that, I just want to thank the Lymphoma Leukemia Society. I was sponsored on a Lymphoma Leukemia Society research grant during my fellowship. You know, you guys have been as well. I mean, the money you guys are raising is what's going to go back for a cure. And 1940 is when this all started. And in the big scheme of history, that's not that long ago. There are plenty of people in this room alive in 1940. 1980s, we were just figuring out what causes cancer. 2000, we were just now starting to use real drugs that actually work without making the patient wish they were dead. I mean, this is a brave new world in medicine, and I'm not quite sure when historians will say we switched from the modern era to the future, but I think it's within a very short period of time if we're not there already. So with all your guys' support, thank you. You do hard work running the triathlons, the marathons, but the money you raise goes to an incredibly good cause, and I thank you for your participation. Good.